that introduction, and I'd like to thank the organizers for the invitation that has been extended. I have the privilege of talking to the clinicians who will be referring the cases to us, so to speak. So, imaging in arterial stroke. I'd like this to be a little more of an interactive session because if I go into the pure imaging details of it, it's going to be pretty boring for a lot of you. So I am going to start by asking a question. If you ask for a CT for a patient, when do you think the CT will be done and the images will be up for review? Less than 1 hour, 1 to 2 hours, 2 to 3 hours? Please feel free. The setting in different hospitals is different, so there is no right or wrong answer. So, what would the ideal be?
Less than 1 hour.
Less than 1 hour, definitely, because anybody has any idea why time is of the essence in management of all acute medical emergencies, more so with stroke when compared with the cardiac emergency. Can anybody say why it is so? We seem to have better results with interventions in acute cardiac events compared to acute neurological events. The main reason being the fragility of the neural tissue. So we have very little time to make very quick decisions and try and intervene. So because of this, time is of the essence when it comes to diagnosing an infarct, an acute stroke. So this is just a definition. I'm sure all of you are aware of this. It is an acute neurological event which is due to a vascular cause. The vascular cause may be a vascular occlusion, a sudden vascular occlusion, or even a vascular rupture. So, stroke is just a broad definition. It can be of an ischemic nature or a hemorrhagic nature. Hemorrhagic strokes can be direct bleeds into the brain or bleeds surrounding the brain. So, what are the basic goals in imaging in stroke? The first thing when there is an acute neurological deficit, a patient with an acute neurological deficit, is to exclude a hemorrhage. Then we should be able to diagnose an infarct, and then of course there is imaging has a very significant role in planning of management options. So pardon me saying that, but anybody call Muniappa from the road and ask him what is wrong with this picture, he might be able to tell you the answer. So this is a hemorrhagic stroke, hemorrhagic hematoma in the left lentiform and thalamic region. Very obvious, very easy to identify, especially in acute stages. So the first goal of imaging in acute neurological event, acute neurological deficit, is to exclude a stroke, because from here the algorithm for management is going to diverge very widely. If there is a hemorrhagic, if there is a hematoma like this, what would the management be for this patient? So the management would, the ideal management for a large hematoma with mass effect and midline shift and edema is a surgical evacuation, a decompressive craniectomy, so on and so forth. So this is pretty much the neurological deficit may get better with time, but there is nothing that we can do from imaging based approaches to reduce the impact of what this outcome is going to be like. Then of course there's a bleed around the brain, subarachnoid hemorrhage. You can see how there is bright signal in the suprasellar cistern and in the hemispheric fissures along the brainstem as well. So this is a subarachnoid hemorrhage. Again, once you identify a subarachnoid hemorrhage, the diagnostic, the management algorithm is completely different. So then comes the ischemic strokes, where we will generally appreciate areas of hypodensity in the involved parenchyma. So I'm going to stop using the words hypo, hyper, and iso, and we will stick to bright, dark, and equal in appearance. So anybody can see this acute infarct in the right cerebellar hemisphere. It is causing some mild effacement of the fourth ventricle and also causing some dilatation of the temporal horns. So this is just a sequence of events that happens when there is perfusion decrease to a certain part of the brain parenchyma. So what are the goals of imaging in acute stroke? These are the 4 P's. So basically to assess the parenchyma, to look at the pipes, that is the blood supply, to assess the perfusion, and then to look at something called the penumbra, which I will explain further. So the whole point is to appropriately select the management. So imaging techniques, like I said, we always like to start off with an unenhanced CT. Protocols vary, but CT is the fastest and the most easiest to get done in any medical setting, hospital setting. So then there is CT angiogram, CT perfusion imaging, and MR imaging. The availability of each of these the second, third, and fourth modalities is variable. Whatever I will be talking about is in the ideal situation. So in CMC, we have access to all 4. I'd like to say that we could access all 4 within the first half an hour of the patient coming into the hospital. Many times we do succeed in not getting the imaging done within an hour of the patient arriving. They are the outliers. But again, plain CT to identify a hematoma, exclude. No more to be done as far as imaging is concerned for this patient. Patient will be probably taken in for surgery. Then we have the CT angio. Can anybody tell me which side is the abnormal side? Just shout, please feel free to say the answer, shout out the side. Yeah, so that's the left side. We are seeing that there's a cutoff of the M1 segment of the left MCA. So you can see how there is a mild paucity of blood vessels on the left side, but all in all, the most important thing to appreciate here is the acute cutoff of the left M1 segment. Same thing, a coronal to give you a better idea. You can again see the M1 cutoff of the M1 segment of the left MCA. Why do you think there are blood vessels here if the M1 is cut off? So there's something called collaterals. Okay, in any part of the body there are collaterals that can come into effect almost immediately following any acute event. So these blood vessels are being supplied via some collaterals which open up almost immediately after the insult has happened. So this is a plain CT. This is just to bring you to the next modality that is used in imaging. Can anybody identify which side the problem is? The same patient had an MRI. So very obviously brings out the disadvantage of CT in the acute, very hyperacute stages of an ischemic event. So the MRI can clearly identify the infarcted area, which lights up like a light bulb almost. So MR under given circumstances, if we have an access to a fast MR short protocol, that would probably be the best way to identify. But because we are in a situation where a lot of time MR is not available, CT most protocols for acute infarct imaging and management are CT based protocols. So quickly we'll take you through some anatomy. I'll just concentrate. That's the ICA, the MCA, and the ACA, and you can see the PCA. I have subtracted out the anterior circulation, the vertebral arteries, the basilar, the PCAs, and the superior cerebellar arteries. So most of the time, imaging is very focused on identifying MCA strokes and treating MCA strokes. Can anybody tell me why that is so? It is, yeah, it is probably the commoner one. It supplies the largest part of the brain parenchyma, supratentorial brain parenchyma, and it supplies almost all the eloquent areas of the brain, which is why I think, which is why the MCA stroke is what a lot of people have done a lot of work on. So I'll just quickly take you over the blood supply of the brain parenchyma. You can see how the ACA, MCA, PCA doesn't really work, as in it's not anterior, it is not posterior. There is ACA and PCA, and then the MCA covers almost everything from anterior to posterior on the lateral side of the brain. So the yellow is the anterior cerebral artery circulation, the blue is the posterior cerebral artery circulation, and the green is the MCA territory. So you can see how, as we go down, the scroll down the brain scan, we can see how the MCA is the dominant artery that supplies the supratentorial brain parenchyma. And larger and larger parts of the brain, as you come to the eloquent areas, that will be the anterior limb of the internal capsule, posterior limb of the internal capsule, the insular cortex. All these are supplied by the MCA. So as we go down, that is the territories of the MCA, ACA, and PCA respectively. And then we start to see the cerebellum, and that's the superior cerebellar artery territory. And then we also start to see the brainstem, and the brainstem is supplied by perforators from the posterior circulation predominantly. And the pink is the perforator supply, and the red is the superior cerebellar artery, and the yellow is the anterior pica and the ICA. So the posterior inferior cerebellar artery and the anterior inferior cerebellar artery territories. And it continues down. You can see how the ICA and the pica territories continue to supply the cerebellum, and the brainstem is supplied by the perforators from the vertebral system much lower down. Anybody can tell where the abnormality is? Yeah, so the right frontal, but you can see how it is not very easy to see, and there is abnormality in a very small part of the parenchyma. This scan was taken fairly early into the after the onset of the deficit. Now the same thing, you can see how the hypodensity has become much larger but not very easily appreciable on the second scan, and that is the third scan, which is done in the subacute phase. And you can see that the established infarcted tissue has separated itself out nicely from the rest of the brain parenchyma. So this is how the temporal evolution works in acute, early acute, and subacute phases of infarction. So we talk about a lot of signs. A lot of time in acute infarcts, we may not be able to identify the infarct reliably on CT. This is where clinical acumen comes in, and when you look at the patient, sometimes you will be able to tell that there is an infarct definitely, whereas the radiologist might be searching high and low for the infarct. So there are a few early signs that we look at called the hyperdense vessel sign. So I apologize for using the word hyperdense here. Just think of it as the bright vessel sign. Okay, and the dot sign. There is a dot, but again the dot is bright. Okay, so these are the two bright signs that you look for, and then the others are the dark signs that you look for. The insular ribbon sign, the obscuration of the lentiform nucleus, and the hypoattenuation of the brain tissue are all darker areas than normal, whereas these are brighter than normal. So this is just to show you how, this is just to give you a brief review of how high attenuation again basically means bright. Okay, thrombus is usually bright, blood is bright, hematomas are bright. So you cannot rely on it 100%. You also have to have a sidedness to it. If you preferentially see a one-sided hyperdensity of a vessel, that is bright vessel, that is more likely to indicate that there is an abnormality on the same side, whereas sometimes you see dense bright blood vessels everywhere in these kind of situations, elevated hematocrit levels, and when there is heavy calcification of the intracranial vessels. Okay, picture 1. What sign is being showed here? Bright MCA. Can anybody tell me which side it is on the second image? Right. So on the third image, where is the... Okay, so you've all become experts. Okay, so there is dense, bright MCA, and that tells you which side the thrombosis, the acute infarct is going to be. Then you have the dot sign. Can anybody see a dot somewhere in the region of the Sylvian fissures? A dot in the right Sylvian fissure? No. Then you can see a dot in the left Sylvian fissure. It is the same bright MCA, a couple of cuts higher up. When the vessel is on fast to the scanning plane, you see it as a bright dot. So it is basically the equivalent of the hypodense vessel sign, a little higher up in the scan cuts. Then you have something called the insular ribbon sign, which is very difficult to appreciate, but you can see that there is a hypodensity of the right insular cortex. Okay. It is a very subtle sign. Many times radiologists miss it. So sometimes the clinician, because you've seen the patient and you already know which side the deficit is on, you may be more easily able to identify these hypotenating insular ribbon sign better than the clinician, better than the radiologist. So then you have the obscuration of the lentiform nucleus, which is seen as hypoattenuating brain tissue, and you can see that the right lentiform nucleus is not clearly seen. It merges with the insular ribbon sign. So this is some technical stuff. Basically, as time progresses, the brain tissue becomes more and more darker as the infarct progresses. So technical stuff, please ignore that slide. When you see a hypodense area like this in a couple of days after stroke, these are areas which are established infarcts. There is nothing more you can do about these areas. These are irreversibly infarcted. So now you can see how in the subacute stage, the infarct becomes clearer to see. But now is the time to start looking for complications. Established infarct with midline shift. So what do you think the management of this patient is going to be? You can see that the right lateral ventricle is starting to dilate a bit. You cannot see the left lateral ventricle, and you can see that when you draw a midline line, the right half of the brain has crossed over to the left side. So the treatment for this would be surgery and a decompressive craniectomy. So in the chronic stage, it's very easy to identify infarcts. You can see that there is an infarct in the right MCA territory involving the insula and the capsuloganglionic region. There is X vacuodilatation of the frontal horn of the right lateral ventricle. You can also see these dark areas, almost similar in signal density to the ventricles. Now I want to bring up this important concept of penumbra. So what is the penumbra? There is the moon and its penumbra, the eclipse penumbra, and then you have the brain penumbra, where you can see that there are different shaded colors here. The central area is the infarct core. This is the area that is already damaged, and you cannot reverse the damage to this area. Whereas there is this other area, which is the slightly darker and lighter yellows, where there is still perfusion. The vessels, the neurons in this region are still alive, but they are vulnerable. So the whole idea of imaging in acute stroke is to identify this bit of vulnerable tissue and see if we can reverse the ischemia to the areas where the vulnerable tissue are, and so reduce or even sometimes reverse the deficits. This is just a slide which shows you what I have already talked about. So you can see that neuronal viability is maintained just for about 2 to 3 minutes. So after that, cells start to die very fast and in the hundreds and thousands, and as you progress there are more neurons which are going to die, and that means that the deficit is going to become irreversible. Oh, I have run out of time, is it? Okay, so that quantitation of ischemic involvement, CT aspect score, CT perfusion, and MR perfusion are used. CT aspects is the most basic thing that you can do with the plain CT. It has 10, as the highest point is 10, which is normal, and you deduct 1 point for the affected, and it is only used for the MCA territory. Now there is a CT perfusion, very bright colored pictures. This shows the infarct core, and this shows the infarct core along with the penumbra. So you can see that there is a good amount of tissue in the penumbra which can be reversed by early intervention. Some MR pictures just to reiterate how MR is very easy to make a diagnosis. So what are the management options in stroke? We have thrombolysis, which is intravenous, mechanical thrombolysis. There's something called sonothrombolysis where they use ultrasound beams, and then of course decompressive craniectomy for large infarcts with midline shift. A small quiz. Which side is the bright MCA? Left. Okay. Some named artery infarcts, bilateral medial thalamic involvement. Is it called the artery of Percheron or is it called the artery of Hubner infarct? Excellent. Okay, so this is which part of the brain is this? Medulla? The posterolateral medulla. So what do you think this patient came with? Lateral medullary syndrome or Wallenberg syndrome. And then which is this location? Is it in the brainstem? Is it at the level of the midbrain? What cranial nerve nucleus might be potentially affected? This is the periaqueductal region. Somebody say a nerve that supplies the muscles of the eye. The third nerve. Okay. So there are a lot of fancy names, named syndromes which you will be knowing better, but these are the imaging equivalents of what the patients present with clinically. So to summarize, these are the management options in stroke, and management depends on the time the patient comes to you, what facilities you have to image this patient, and of course having a good intervention team and a neurosurgical team is important. Any questions?
Dr. Pavithra has covered a very difficult topic very lucidly. I've been pleased to take any questions.
You can write on a piece of paper and hand it to the volunteers on the floor as well.
Madam, when you are planning for a TIA, what type of imaging you are supposed to take to get the maximum results?
Okay, so TIA is a different ball game altogether. Maybe Dr. Vivek can tell us what he'd like to do for a patient who has a TIA.
So for a patient with a transient ischemic attack, and the patient was recovered, we're actually would be more worried about him because we don't know when he's going to have the next stroke. So to know that's one question. The second question is that was it really a TIA? Was it, or is it a stroke? Which is so now with the advent of imaging modalities like diffusion weighted imaging, we can actually pick up smaller strokes as well. So the imaging modality of choice for somebody with a transient ischemic attack who has come to the casualty would be an MR imaging, where we would do the minimum sequences would be to do a diffusion weighted sequence and an MR angiogram. The reason being MR diffusion weighted to pick up small infarcts, and the MR angiogram to make sure that the vessels are okay, to know whether the patient is at risk for having a next stroke early. If there is any abnormality in the vessels, the patient would have to be put in. Otherwise, the patient can be sent home as well. So we should not send a patient home giving a slip for an imaging to be done on OPD basis. Anybody with a TIA, if it's recent, should definitely be evaluated. And the MR angiogram would be from the neck upwards.
This question to both Pavithra and Vivek. You are in a setup where you don't have CT scan or MR in your hospital. It's 4 hours distance away. Patient, typical stroke, older, diabetic, other risk factors, and acute onset of a hemiplegia, facial weakness, etc. So, should we send that patient over that 4 hours drive away for the CT scan, or you manage in your setting?
At this point, we have already lost the window of opportunity to do anything that could potentially reverse the patient's deficit. So at that point in time, the goals of imaging would be, one is to make sure it's a stroke, that it's not a stroke mimic. And the other thing is, of course, to image his vessels to see if he has potential problem areas which would help you to prognosticate for this patient better. So I would not hurry the patient out for my first thing would be to stabilize the patient and do whatever is necessary. And then to send the patient, once he is stabilized, he or she is stabilized for the imaging. The imaging is only to tell you, to prove to you your clinical diagnosis, and also to help you manage the patient further, and also tell the patient if you are at risk or prone to having other strokes, like treatment focused imaging, that is a delayed management focused imaging is what would be. I would not encourage you to try and send the patient immediately to get a.
The Chinese aspirin stroke trial, before the thrombolysis, CT scan was not mandatory. If the physician thought it was an infarct, you could give aspirin, and so there was a benefit from giving aspirin.
Yeah, so it may be a bias from our side, but having seen small bleeds mimic infarcts, it would be difficult to justify giving aspirin. And it probably maybe nowadays CT penetration is very good. District level hospitals also have CT. I know that there are places in the country where it may be difficult for 4 to 5 hours to get a CT. But if the patient is stable, I would probably prefer to wait till getting an imaging done. And so now many more things are being done with teleradiology. So they do the imaging and they send it to Bangalore, and they can get it reported right away. There's some questions, Dr. Pavithra, from the audience. Any role for for management more. Any role for dual antiplatelets in ischemic strokes? How long we continue dual antiplatelets? What is the initial and maintenance dose of atorvastatin?
Okay, all these questions are for Dr. Vivek. So,
Sure. So, I'll go with the atorvastatin first. And just 3 days back, we had a patient who came in from a peripheral hospital, a stroke. He had a stroke, and he was given 300 milligram of aspirin, 300 milligram of clopidogrel, and 80 milligram of atorvastatin, and 5,000 units of heparin, and was referred. He had a CT scan. The CT was showing no bleed. So so this is probably the extension of the myocardial ischemia guidelines, which is being more applied to cerebral stroke. So from our point of view, the management of the acute stroke is more based, more now guided towards thrombolysis or thrombectomy. So, and if it is likely to be a large infarct, we don't actually give antiplatelet right away. because once you give the antiplatelet, then you have to transfuse. Before, if a patient requires a decompression, it becomes very complicated. You have to get blood products and then take them up. So if we have a patient, our algorithm, our current algorithm is now CT based. With an acute stroke, it is dependent on whether the patient is likely to have a large artery or a small artery infarct, which is based on a clinical sense. Accordingly, we decide whether the patient will require just a CT brain alone or a CT brain with a CT angio, and then we take it further from there. If there is a doubt of a stroke mimic or a doubt of a posterior circulation stroke, or the duration of the stroke is not very clear, then we'll go for an MR-based imaging. The only reason for this is that the CT is somewhat easier to get done than an MR stroke protocol, despite having 4 MRIs over here. So the dual antiplatelet in a TIA situation where you've seen that the vessels are all right would be reasonable, and we would usually give it for the first 3 months, and after that put them on single antiplatelet if the vessels are okay. And dual antiplatelets in ischemic stroke per se, if the patient has a lacune, it doesn't need a dual antiplatelet. But if the patient has some vascular disease which we are not able to intervene, then again dual antiplatelet is an option. Again for about a period first 3 months, and then we go back to a single antiplatelet. The dose of atorvastatin, we do not routinely give as high as 80 milligram, but we do give 40 milligram for the first month or so, and then we bring it back down to 10 or 20 milligram. We are not as aggressive with statin as the cardiologists are.